Hi, everybody. Thanks so much for joining us on another episode of the Med List. Donna, this is our last episode of season 2 of the Med List. I cannot believe that we've had so many incredible guests on. It's been a real pleasure just to be able to spend some time with you in these afternoon evenings. Any other big pieces do you feel that you're kind of reminiscing on our last episode of the season?
I am so glad you asked. And we did not even plan this, Kevin, but I looked up. We've had a total of 26 episodes, and I'm really proud of that. I think we're doing amazing work here. I'm so excited to see how many more episodes this goes for throughout our season 3, but I can imagine that we'll be pretty close to that again. So I just wanted to say thank you for sharing your time with me too, and with all of our guests. I think what we have here is pretty special, and I hope that our guests and also those that listen think the same thing and are learning as we are learning.
Amen. Well, thank you. And speaking of special, we got a special guest on today and really excited to bring her to you guys to talk about some really basic things that I think we're all missing to be able to help with this massive medication management problem. We'll see you in just a sec. All right. They have some different bars and things or little eateries, Donna, that are like the dueling pianists that are playing back and forth, right? And I'm really excited to hear the dueling authors talking about medication management, playing back and forth off of each other. So without further
Yeah,
ado, I'm sure excited to bring Hedva aboard.
that's awesome. And thank you, Hedva, for joining us. Yes, I love dueling pianos too. How did you know that about me? Um, I think that they're just so fun to listen to. I've seen them where there's like 6 people playing playing 2 pianos. How neat is that? Anyways, so I'd love to introduce our guest, Dr. Hedva Barenholtz Levy, excuse me. So Hedva Barenholtz Levy. She's a doctor of pharmacy and board certified geriatric pharmacist, founder of HBL Pharma Consulting, a senior care pharmacy practice in St. Louis, Missouri. She is an adjunct faculty at St. Louis College of Pharmacy and author of Maybe It's Your Medications. Dr. Levy is past president of the oh my gosh, I'm so sorry, the American Society of Consultant Pharmacists, and received her PharmD degree from the University of Michigan. And here's a picture of her book. So welcome very much. Thank you for joining us, Hedva.
Oh my gosh, thank you guys for having me. And I love the introduction, the dueling authors and the pianos. I love it.
Yeah.
Great to be here.
Yeah. And I think we're going to make some beautiful music, Hedva, because I think our messages are so important. I think we share in our passion of helping older adults and getting the word out that we have a problem, and it's called over medication. And I want to talk to you about that. And I know Kevin does too. So thank you so much for sharing your time with us and sharing this very important issue and your sights and insights with it. So, so I want just to get started a little bit about you. Um, and I know that our books came out kind of in a similar time frame. I think within maybe a year of each other, if that. So I know that I had my reasons for writing my book. I'd love to hear about your reasons for writing your book too, and just how your journey got you to geriatric pharmacy and really wanting to share your passion with others.
Absolutely, because the timing was very similar as we evolved. So I started off not. I was always I grew up not knowing that I would end up as a pharmacist. I'll start with that. I didn't even know what a doctor of pharmacy degree was. I went off to college, University of Michigan, and was thinking business or medicine, and soon realized it wasn't going to be business, but I wasn't quite sure that I wanted the full medical track. And lo and behold, I was fortunate enough to learn there was a pharmacy school at Michigan, and there was this thing called a PharmD. So the whole thing really came to me, much to my surprise, I guess, when I was a sophomore in college. But I entered the program, never looked back, got my PharmD as well as a BA at the University of Michigan, and went onward from there. I love pharmacy as a profession. It's given me so many opportunities. And so it's been so fruitful for me and fulfilling. I had an interest in geriatrics kind of as I was going through pharmacy school. I think for many of us, we have a relative or, someone that touches our life who's an older person. So I definitely was influenced by my grandparents, I think, and was leaning towards geriatrics in a way, not knowing how much so. What I did after I got my PharmD, I did my 1-year residency. I ended up back in Cincinnati, where I worked full-time as a clinical coordinator at a small hospital, bringing pharmacy up from the basement, doing what you're trained to do at that. This was early 1990s. But I also worked part-time at the Annals of Pharmacotherapy. And I like to share that because that writing component, the love of literature, the medical literature, peer review, journal articles, that type of thing has always been in my bones as well. I've really appreciated that. And Harvey Whitney Jr. is one of my mentors. So I was back in Cincinnati with the journal and working working full-time as the clinical coordinator. Had this interest in geriatrics. There's this unique model I had read about of a pharmacist out in the DC area. This is in the late 80s, probably, working with older adults in their homes. Really unique community-based setting practice. And I had heard about that model, kind of kept that idea with me with my training and with my first job. And when I met and married my husband, I knew we were going to relocate to St. Louis. And I interviewed this woman in Washington, D.C. about her practice model. So I took that with me. Short story here. When I moved to St. Louis, I started a senior care pharmacy practice. So I knew by then I wanted I had interest in older adults. I just saw this population as one that kind of fell between the cracks, those community-based older adults who were asked to take their medicines and really didn't know quite what to do with those medicines. I saw my grandmother having a lot of questions, my grandfather being overly concerned with every symptom he had and some more little hypochondriac kind of thing. But it all kind of influenced a little bit of my wanting to work with older adults in the community. So I started that in St. Louis. And that's where my journey towards this book, I guess, started. But I can tell you, I had no idea, and I love to hear some of your story too. But what led to the book essentially was 25 years of working with people in their homes, seeing what they were doing at home, what they were asked to do by the healthcare team, the questions they didn't know they needed to ask, the medicines they were combining without realizing. Maybe I should talk to my pharmacist or my physician about the over-the-counter products, or not even recognizing they weren't taking their medicines correctly. But it was so I saw lots of errors, and we can talk and get into that a little bit more, not only from what the patient was doing at home, but what the physicians were prescribing for the older patient, and also even what was being dispensed from the pharmacy. So just lots of sources of errors. And I think that love of writing and the literature, writing reports to the consumer, so always a lay language and very simplified language, if you will, with my reports, it was coming together that I was going to write a book to the consumer to help address all these preventable problems. And I think we were talking a little bit before we went on about overuse of medications and not really thinking about the impact. So
love it.
The book, as I say, was 20 years in the idea of sorts, in the making, 10 years of knowing I wanted to write a book for consumers, 5 years in figuring out how to become an author, 3 years in figuring out how to do it. I wanted to go traditional publishing. So how do you get an agent? How do you go that route? And then, everything kind of worked its way through that. I got an agent, got a publisher, and was able to get to the book. But it really comes from seeing that we can do better. We can prevent problems and be safer about our medicines. And this is a way to reach a bigger audience by putting a book out.
That's beautiful. I think the one thing I grab onto and really want us to dive in a little bit is this. When writing a book, like when putting something together in text format, like you both have, and several other authors have put books together to try to help us understand a very complex topic of medicine, right? What do you feel right now are some of the big misses out there in consumer medicine when it comes to understanding medications in the very basic level of just someone going first time ever, being diagnosed, getting a new medication? Where are the big holes that people are falling through initially that lead to some of these problems, especially with early communication and over complex communication early?
Yeah. Well, a few different answers come to mind, and I can go different directions. But one of the ones I want to start with, I think, is understanding the goal of therapy. Why am I taking this medication? And that there's all these other pieces that are wrapped into that. So understanding the health condition that the drug is treating, but what the drug is supposed to do for you. And I often, when I speak to groups and talk to patients, I talk about understanding the goal of therapy. That's a way not only to evaluate, is it helping you, but are there side effects? And if it's, and again, is it helping you? If it's not helping you, we need to look at that again. I see so much prescribing inertia, right? Where things are continued, and we don't think to question it. So to understand why you're taking a medicine, I think is so basic and can lead to preventing downstream effects. Think about even choosing an over-the-counter product maybe, or dietary supplement. What is my goal in taking this medicine? That could lead to a conversation with the pharmacist about choosing the right over-the-counter product to make sure it's effective or necessary, let alone with the dietary supplement. We go to medicine so easily. The product is out there. Think about, let's talk about non-prescription for a minute. It's out there. I can take it freely. It's natural, or it's available without a prescription. It's got to be helpful. Let's try it. But so then we start adding on medicines and not realizing that there could be interactions or an adverse event with other medicines they're taking. So that's
I think I love the comparison of just trying to bring some elements into the fray of just why are you doing it in the first place, which is great goal element. I often like to think of this. We have things like IMDb and Rotten Tomatoes, right? To be able to help us. We're going to watch a show or a movie. We have a good idea on parental controls. What kind of things are we going to be exposed to or could be problematic? We have the ability to rate those things on a scale of like, what's the overall benefit or likely utility of consuming it? We don't often have that, Donna and Hedva, when it comes to medications, right? In any way, shape, or form. It's just simply, we go in, here's your problem, here's this long, often multi-derived Latin component name that no one can pronounce, and now you're going to take this medication for who knows how long. Good luck and Godspeed, right? And that's where we leave folks today. So for you guys, when it comes to that conundrum, Donna, I'll throw it your way. When it comes to that conundrum that we hit right now, when it comes to literature currently being in place, we have a lot of new technologies to be able to say, well, what if we took the patient counseling component and we make it in paper form, in a simpler paper form that we hand to the individual? What if we make it in video format? What if we make it in all these other point solutions are kind of there? But you guys both took that and said, no, we need to back out further, right? And analyze the entire problem. Why did you do that, Donna? Why did you not think it was just enough to have a point solution for every single drug? You need to talk about it more holistically.
Yeah, well, I think I heard myself saying similar things over and over again and again. And then I'd also hear similar things from the patient side. So, and I just felt that this one-to-one is great. Like, I'm glad to be that one-to-one person, but if I keep hearing the same things and needing to say similar things, there's got to be a lot more people out there that also need to hear this. And there was no way I was going to be able to speak to every single person. So my hope was that putting it out in print form might allow for that conversation to either be thought of, to be started, or maybe answered even. Maybe people already have these, questions, and they're trying to figure out what the heck am I supposed to do with this? Here's mom's or dad's list now that I'm caring for them. I'm blind here. I have no idea what to even do. And so I think that was the reason for me. Like, if I had to really drill down, is there was so much going on that in trying to come up with something that was like, what can people learn? What can people do? What steps can they take, kind of thing. So that was kind of the lean into my book. And like Hedva just said, like, why is somebody taking something? I also think one of the big issues is, how long am I supposed to be taking this for? So many people hear, I need to take this for the rest of my life, or they grab a supplement. It helps them out potentially, maybe not, but they think, oh, I'm not feeling any worse, or I might even be feeling better. So therefore, I need to continue this. And no one really thinks about, how long have I really been on this med for? And I'm sure Hedva can also say, like, how long have you been on this for? And we see like 20 plus years people are on the same medicine. So Hedva, I don't know if you feel the same way, or if you have other things to add to, as to what really hit you. I know you mentioned like all these years of hearing and practicing, and but what do you think in regards to that whole literature piece? Like, I know we hand things out to the from the pharmacist, right, or the pharmacy. There's these big long things that are not very attractive, that aren't very health literate or friendly.
Right.
People are scared when they go, I'm not going to take this now. And there is lacking that context in conversation. So why did you, like, with all of this, why did you decide on a book instead of, I don't know, a video or something like Kevin's suggesting?
Right. Well, and one, I'm a bibliophile. Is that the word? I love books anyhow. Right. So that's my nature, period. But it's as it's evolved, it is a way to reach a broader audience. This message needs to be screamed from the mountaintops. And this is a tool that I am at least contributing to put the word out that we need to be talking about our medications. And same with yours. The message of reevaluating them, optimizing the drug therapy. So I always say with my book, my approach in general in life is I'm never going to bring up a complaint without a possible solution. So I say that for personally, professionally, whatever. So my complaint is we're making too many errors with our medications, with the prescribing, the way we're taking them, the way we're dispensing them, everything. But so the back third of my book is designed to give people tools and tactics on how to prevent those problems, how to be safer about avoiding medication errors, how to advocate for their medication needs, how to avoid interactions. But I also feel it's important that people know the background of why we need to care, because I think it's also interesting. You can't just say to an individual, you really should, talk to your doctor or pharmacist about your medications. They're going to say, why? I'm feeling okay. And, it's doing okay. It's not hurting me. But to understand that, I start off with talking about why, as older adults, we're at higher risk of having problems. This is the background for why you should care. So I kind of put in there as well, in case you're not sure that you need to worry about your medicines. I kind of argue why you do need to worry about them a little bit, or think more carefully about them. So yeah, it's a way to get a broader reach. I guess, yeah.
I think that's so poignant there, Hedva, when you said talk to your doctor or pharmacist about something and you not being satisfied with that statement. It's so difficult to ask that question when the individuals we're asking it toward don't even know what questions to ask in the first place, right? Or where to look or where to turn when it comes to some of this information. And that's why we have experts there. The real problem, I think, for me overall, though, is if we lean on that statement, because pharma has leaned on that statement for quite some time, like literally almost every single pharma advertisement will say something along those lines, talk to your doctor or pharmacist. Well, that is a cop-out, terrible cop-out. The problem I have is on the other side, though, and I'd like your guys' opinions on it. What about on the medical education side? How are we failing our patients right now, and what do we need to pivot? And it might not be just medical and pharmacy education. It could also be just systematically. But where are we leaving huge holes and gaps? Because we can't put, at least my opinion, we can't put all the pressure on the patient to say, you have to be your own advocate and take care of this yourself. That's like asking someone to have multiple degrees and backgrounds and have a second job. And it's unfair. It's something that should be the expectation of our medical system in one way, shape, or form. What are your thoughts, Hedva? What things do we need to change pretty significantly within both the educational setting and the holistic kind of healthcare system setting to better achieve some of these common goals of medication management for our patients?
Yeah. Well, I only know the pharmacy training side of it, right? I know, and unfortunately, I'm not involved in training health medical. I've been involved in some interprofessional, but not in the fellowship side or whatever. So
Sure.
and I know pharmacists who are involved in training the medical profession or how the interprofessional nurses, what have you, the other professions. We can imbue in that training the importance of medications and the kind of questions that the healthcare professionals should be asking. I struggle when I make my recommendations. I'm working with the patient, family members if I can. I have lab tests when available. I never want to assume that the physician has all the knowledge about the medications that I do. I think when we make that assumption, that's where we end up with things falling through the cracks. Kidney function not being assessed, or the dose not being adjusted because, so I'm careful not to make those assumptions. I don't want to offend my colleagues who are prescribing, but better safe than sorry, because the one who suffers is the patient. Right now, our healthcare system is at a breaking point in a way. I think something has to change, because with the way the costs are going up, the segregation of the way we provide care, it's disjointed care.
Mm-hmm.
Who is really looking at the patient from their perspective? So I love this person-centered approach and shared decision-making as our new paradigms to provide quality care. But are we really looking at it from the patient's perspective? Because it can be overwhelming. And I think because we have a disjointed healthcare system, because the pharmacy is over here and the medical system is over there, and the one who's prescribing or suggesting we do this is not the one paying it, it is complicated. So I'll kind of pause there and see if, Donna would jump in, but
yeah. So Hedva, and this is a perfect time for me to jump in with something we had talked about previously. And something that struck me is we often think about, if you add on the number of drugs, there's more adverse side effects that can occur. And yes, that makes complete sense. One of the statistics that you brought forth that I was reading about, I was like, oh, wow, this is really clever and interesting how this is presented, is that the number of prescribers, as we increase that, there's an increased risk of adverse events. And I'm like, whoa, that is quite a statistic. So when you're saying we have a disjointed healthcare model, if you will, and system, the statistic is like, so, right up front, and it needs to be looked at and addressed. Like, so how do we do this? Like, how do we take care of this whole disjointed system that we have, and maybe work better together? We still need our specialists, of course, but how do we prevent this from happening, do you think? I kind of rack my head around this too, going, not another prescriber, like, no, we got to roll back a little bit, or we got to communicate better or something. So have you thought, and I know we talk about like we try to be solution people, but any thoughts on that? And I think that's an important factor.
So just the communication between the different prescribers, and how can we get our heads and really hands around improving, dealing with that fact.
Yeah.
I don't know how it goes away. We work on this universal health record, right? With the electronic health record, which, as some will say, it's a little bit of a joke. We're not there. It's not the answer necessarily. I think it can help. I still have the dream that you have one primary care physician who, typically the PCP, the primary care doctor, is going to be the one, maybe, I don't want to use the term quarterback. Some people don't like that term, but to oversee. I really would love to see the one physician has to have the oversight, rather than, as I've heard patients tell me, my cardiologist only asks about the medicines he or she prescribes. So that informs me that doctors aren't always looking at the whole picture of the medicines. But I'm concerned that the general practitioner, the internist, if you will, that the person sees, may not be the one to have the communication with the specialist either. And I think I would love to have everyone around the table having a conference call, if you will, about a patient situation. But how are you going to get 4 or 5 physicians together? They will tell you it's not practical. And I get that. So that's where my practical solution right now is you as a patient have to advocate for yourself with that medicine list, armed with questions you need to be asking. A lot of times I'll tell people, use me as the scapegoat. Just tell them you had this review by a pharmacist and she told you got to ask about this or this. Blame it on me that, you're asking these questions.
Right.
Exactly. I don't know that there's a good answer, though.
I don't know if there's a good answer right here now either. But Kevin, what do you think? Do you have thoughts on this? Like, how do we better communicate? And I agree, like Hedva, when you're saying we need that point person. I personally think geriatricians are really good at being point folks for older adults in reducing unnecessary and inappropriate meds. I think that they tackle that problem for the most part. I think they're more willing to, shall we say, and dig in more, where I think the model for like a primary care, not necessarily, and I don't mean this in a bad way, I think that their point of care is to make certain that whatever is the problem is being addressed by the appropriate specialist. I think that's how it's been formulated. I'm not saying it's wrong. I'm just saying I think that's how it is. And so they're like, are you seeing these specialists versus let me make certain that all of these specialists are melding and that you're okay. It almost has to come back to them. I think PCPs point out.
But you've got the patient who has the falls and who has 4 different medicines or 5 different medicines that are affecting the central nervous system that impacts the falls that are not being prescribed by that primary person, or some of them are. Someone has to take the initiative to say this person is falling, is high risk of falling again. A lot of these medicines are being prescribed by different specialists. We need to talk about how do we reduce the dosages or eliminate one of these medicines or something.
Yeah.
And how do you have that conversation?
And even in the hospitals with the hospitalists, it's really hard to have them go beyond what that acute problem is. So back to you, Kevin, with that question. Any ideas at all? And I'm sorry to put you on the spot, but how do you see the communication change?
Yeah, I think it's a good question, and it's incredibly necessary, that we get very uncomfortable with that question right now.
Yeah.
So one of the things that we get to talk about with our audience here in particular is, what makes the needle move in healthcare in general? Like, why are you prescribed these meds? Why are your visits formatted this way? Why do your practitioners, your care providers, think of you in the way that they do? And one of the biggest drivers of anything in life in business is money, right? And so the incentive system currently inside the United States is somewhat fractured, but primarily it's still a fee-for-service system, meaning you go and there is a transactional nature and what happens, right? You go in and you have a primary concern or a primary diagnosis or a primary problem that you're trying to navigate through. You have that encounter. There is an encounter rate. They are paid for that encounter rate. The prescription goes off to the pharmacy, and there's a hand washing and on to the next patient, because I have about 7 minutes to be able to see each patient, and I've got to move them through to hit what are called RVUs, or value units, basically, for these practitioners to be able to justify their existence and their salary. So now that we've established like that is how the hierarchy works and why the engine works the way it does, it makes sense why we end up diluting products so significantly because of that, right? There's not incentives to make it better. There's incentives to do more. And so I think one of the biggest things that we can do for that communication pattern is really reevaluate the way that we are working in teams. As Hedva was saying, it's really sad to think that 2 things. One, that it's impossible to be able to get a group of individuals in a room, right, to be able to talk about a coordinated care kind of paradigm, but it's difficult. You've got very highly compensated individuals that you're hoping somebody's got to take onus of this. Somebody's got to be the quarterback, as Hedva pointed out there. And I think it really is, depending on the part of the country. I was just listening to a podcast this morning talking about how we practice across the nation. So particularly the Northeast is pretty prone to high specialty utilization, as opposed to the rest of the country being very primary care oriented, and then allowing them to point and do some care coordination kind of components. But I will say there are some models that are in place already that are looking at something called value-based care. And I think when it comes to value-based care, sometimes it can be used as a buzzword, right? In general, like, oh, this is going to solve all of our problems and take care of everything. But from an incentive alignment standpoint, if we're trying to make our patients better, right? If we're trying to give, as you guys both point out in your books, try to give some level of onus, right, to the patient to be the champion and potentially the quarterback of their own team, I think this is the best level of alignment, so that now we have a payment model that is based on how well are these patients doing, right? What are their general outcomes? And that forces people to be able to have these difficult conversations about maybe that was the wrong drug, right? Maybe we do need to change the therapies in general. We do have to care about the side effect profiles and if someone's going into an ER visit. And so I think when it comes to how do we do a better job, it's really the structuring and the payment models that we're operating under is the first thing that has to be examined. Otherwise, all the other thing is just lots of talk. But anyway, there's my 2 cents.
So Kevin, thank you for that, because as you've been speaking through this, I'm like, why am I even questioning this? It's the pharmacist, right? We need this pharmacist model who's reviewing all of these meds, and we're the center going back to everybody and saying, we've got to make a change. So this is the model that we need, is to make certain that pharmacists are being paid for their knowledge and skill of understanding medications and med reviews, having the time and expertise to do it, getting paid for that, and being able to fill that, press that out or push that out to other providers, the providers that in making those adjustments for the patients. So the system is broken or not working well. And instead of trying to fix it, we need to change it by employing pharmacists to be a part of this. And that's my solution to this situation.
To tack on to what you said, Donna, and you both covered key things because of these 8-minute visits or 7-minute visits. We have a reimbursement model is such that it's much faster to write a prescription and move on rather than talk about one's nutrition, one's stress levels, one's physical activity interests, and whatever, all those the non-drug ways to help our health. I also, the pharmacist, when I talk about the value of having a pharmacist do your medication review rather than even your physician doing it, is a pharmacist is because a pharmacist has these outside eyes. We're not invested in having prescribed everything. We're looking at everything that has been prescribed, plus everything that you are taking individual, because you're taking things without a prescription, often OTCs and the dietary supplements. We're looking at everything and really drilling down to how you're taking it. It's not just looking at your paper list of medicines, because you miss so much by looking at just a list. The fact that someone's not taking it, they're taking the alendronate, the osteoporosis medicine with lunch at noon, but if they're taking it every week, their refills are on time. They, you don't pick up on that stuff, or they're not taking something or something that's not treated.
Right.
But that pharmacist piece is wonderful. How do we get us everywhere? So I do argue for we need to be reimbursed for our cognitive services. And then also to dovetail, just to mention, remember the geriatric training, like you mentioned, the geriatricians, the value that they bring to the table. We have less than 1% of physicians and less than 1% of pharmacists are geriatric trained. And we've got 17 more million older adults in the next 6 years. By 2030 is the number I've been kind of put to paper. We are going to be overwhelmed. We don't have enough healthcare providers with the knowledge to understand the nuancing of the older adults and the medications. Just want to add those little pieces because you guys are hitting everything spot on.
Yeah, totally.
I think that's an interesting kind of segue there, Hedva, on when it comes to the bandwidth, right? The bandwidth of what we currently have inside of healthcare. It makes it even more appropriate for some piece of literature to be out there, to be able to help patients, to be able to gather a little bit of that information and recognize. I mean, you guys might have experienced the exact same thing. In fact, I know Donna has, because we've had lots of conversations. Getting an appointment right now, it's impossible. I mean, you're on your deathbed or the emergency room, and then you can get seen because you're in the ER, right? But otherwise, being able to see your primary care provider or even a specialist, very difficult right now. And you already mentioned had some of the difficulties of seeing your pharmacist, right? And what the priorities are of those individuals when you're going in to see them. So when it comes to like the lack of bandwidth in the healthcare system today, right? And what patients can currently do to be able to take care of themselves. Let's say someone already has someone at home, right? Someone at home that has a significant number of medications they're already taking. What would you guys advise, since we have about 10 minutes left of our time together, what would you guys advise they do? Like, where do they start? You've got mom or dad, uncle, aunt, yourself. You've got 10 medications staring at you on the counter that you have this pill sorter to be able to look through. What's step one?
You're talking very pragmatically, like at home versus before you call your pharmacist to get that medication review of sorts? Or
there's no pharmacist kind of medication review inside of there. They're just starting from.
They're just going, oh my goodness. Yes.
Yeah. Well, I'm not sure. There's the. I would start off, and I know there's different ways to how do we parse this down.
Yeah.
But by general education, when I'm able to give people the starting point is that medication list. And I'm not sure which piece you're going. One, you have to understand everything the person is taking. Then there's the adherence. How are they following those instructions? Are they taking things correctly? But my concern is people don't know what they don't know. They don't know what they're doing incorrectly at home because it's being missed, right? I mean, I'm sure Donna has seen the similar types of errors. I always use the common example. Medicine is supposed to be taken twice a day, and the person is taking it once a day. And when I ask them, look on the bottle, look at the instruction, they're like, oh my gosh, I didn't know that was twice a day. How does that happen? I don't know. But so those are just the weird types of errors that can happen. But filling out that medicine list, and again, knowing why, I mentioned the goal of therapy earlier, but why you are taking a medicine. And if you don't have a reason and understanding of why you're taking it, that's a great place to start with asking questions. But it's going to come back then to sit down with your pharmacist. And I always will emphasize our profession, we have the most information about medications.
Yeah.
So how do you work around, we can't be everywhere, but I think we should be made. I'd love to flip the pharmacy and have the pharmacist is out there talking about medications with every individual at the pharmacy.
Yeah.
Technicians can do the filling.
Yeah. There's some great models up in Canada, pharmacist first. You sit down with a pharmacist when you're given a prescription versus after the fact, and you go through everything right then and there, and then it gets filled. I love that. I think that's brilliant, and it works, and it's been working for decades and up in Canada. So I agree with you, Hedva, on a lot of that. I think when people are just like completely overwhelmed, I think it is the good questions, of like, so why are you taking this, or what's the issue? Does the issue still is the issue still an issue? Like, how many meds is somebody taking that of something that happened years ago? I've talked about this before, Kevin, with even seizures, right? I haven't had a seizure in 40 years and they're still on anti-seizure meds. Like, that's crazy. When was your last gout flare? Was it a decade ago? Did your body change? Are you not eating the same foods? Or, there's a lot of changes as we talk about, whether we mean to change them or they just have happened over time. We change, and our habits change, and maybe what we put in our bodies changes, or the amount we can put in our body changes. I think too is that we've got to be looking at the products, and I am going to do a little segue into something else in regards to looking at the products. Are they even practical for folks? And Hedva, you had mentioned another thing about like the regulations, right? That there is the FDA regulates the prescriptions, right? But it's but over the counters, there's not really any regulation. So even the size of the pills that are made prescription wise are regulated and not regulated with supplements. So could you talk a little bit more about that and like what you found when you unearthed that information? Because everyone talks about these huge vitamins and things like that they're taking, and how am I even ever going to swallow this? And so what did you find when you were looking at that? Because that's an issue too. What are we giving people, and are they even able to take it if needed?
Absolutely. Or are they splitting something on their own that maybe should or should not be split, and they don't know to care or worry about it? And then as a pharmacist, I'm like, wait a minute. But in doing the research for this book, it's all third reviews I'm sorry, it was a review of the literature and looking at primary studies to get my data to support it. But there's so much out there, I guess, going back to my love of the peer-reviewed literature. When I came across that study that had to do with I have a chapter on the non-prescription medications, how they're regulated differently. And that just came upon me as I was doing the research and finding data that talked about the decreased ability of older adults to take some of these medications. So I can't speak much more to that, except that if we look, we have research. There's so much out there that there's research on. It's just a matter of finding that information and making it relatable and understanding that we have to look at the patient's experience with these medications and also teach patients to say something. Again, bring up a question or concern. So many times they think, I'm just going to muddle through. They prescribe the whatever, even a potassium pill that's very large, or the multivitamin or the calcium. Bring something up, because if you're not taking it, it's not helping you.
Yeah. Or having difficulty swallowing it, or, you might have been fine, taking it a few years ago, but again, things change and maybe you're having difficulty swallowing now. So what are you trying to do in order to take care of those things? So I think it's so important that we talk about things change. And I think we can all agree on that. And the messaging that we really need to get the message out that just because you're told or prescribed something and it's been years, or even something brand new, you got to be thinking about that product and all the products that you're taking. And what is this for? How long am I supposed to take it for? Is it really necessary? Is it really appropriate? Do they have the full story? Was everything reviewed? There's a lot to it. And we all play a part in this polypharmacy, whether we're the patients, the providers, or the healthcare system. Everyone plays a part in the polypharmacy and in the problem that we're over-medicated, and really thinking about how each one of us in these areas can change that and make a difference, I think is really important.
That's so helpful. Yeah, I think you guys both bring up great topics on all sides. I love the OTC component that you pull in as well. So a few companies that I've worked with in the past have really delved into this question, like, where is the centralized med list? Like, where is it, right? They can tune into it here, which is great. But the actual med list, right, for an individual patient, the only true med list in the outpatient setting is what does that person put into their fingers and into their mouth, or inject into their body, or try to puff, right? So that's the only med list. All the other ones are lies. So I think that when it comes to the first place you have to start, it is your own personal med list. Like, what are you actually taking? How are you actually taking it? And then from there, disseminating that list to all individuals and parties that could be involved. Just like Hedva saying, get it to your pharmacist. Make sure your pharmacist knows everything you're taking, including your OTCs. Get it to your primary care providers. I think that communication mechanism can't start anywhere until that list is fully assembled, and then you can start parsing out the individual details that can be broken down. But it's just essential that if we got anything out of these 2 seasons that we've been doing this, and if these 2 incredible women have gotten anything out of their books, please make sure you have a med list on hand, right, for your entire team to look at and to evaluate in the very first place. I'll leave, I guess, with this question, Hedva, for you. So you've been president of ASCP, which I shout out to ASCP, love ASCP. Don and I are trying to do some things inside of ASCP related to some different models for pharmacists to get more involved, which I love. You've worked in different states. You are a Michigan alum. Like, you've got all these little background pieces. What's next for you? Like, what are you going to do next? Where are your kind of hopes with not only the book, but your career?
Wow. Thanks for putting that one at the end. It's interesting because I talked so long about once I decided on the book, I want to get this book done. And now I have it done. And I thought, okay, that's the accomplishment. Check mark. I've done it. But I can't let it sit, because if I don't promote it, and this is the world of authors today, the book will not be known. So anyhow, so my next phase right now is focusing on continuing to put out the message about safe medication use. We can do better. I think when I put my epilogue together, the end of my book, the afterword, there's something in there for patients, for providers, for our healthcare policy people. We need to appreciate that we can do better with the over medication use.
Yeah.
The numbers you probably have talked about at some point in these last 2 seasons, $528 billion in healthcare due to suboptimal medication use. That is preventable. So we all need to be leaning in somehow. So my next phase, I thought it would be more clear at this point. I don't know. In a way, I love what I'm doing. I'm teaching part-time. I'm working with my clients in their homes. Even though I think I can hang up put that shingle away, if you will, I get the referrals continue because people continue to need very personalized attention out in the community setting. Promote the book and make a difference. I would love for the conversation to shift in America about medications, and not how do we cap the price of insulin? How do we use fewer medicines or use them more properly?
Yeah.
So we don't have the trickle down wastage and unnecessary medicine use, the adverse effects, all that stuff that can be prevented. So that's my big thing. But one person at a time, one message at a time, talking to groups, ask questions. Consumers have to step up and work with their healthcare team. So sorry, it wasn't a shorter answer, but
That was beautiful.
Perfect. And yeah, just the continuing that message, right? Hedva, I loved how you said you're having a lot of fun now too. And I feel like there's so many similarities that have come through that I'm like, oh my gosh, that's exactly what I would say. But I say that too, like I'm having so much fun now with just getting the message out, right? And who you're meeting and who you're speaking with. So it is pretty neat to be on that side of writing a book and being able to share the message that you have. And so congratulations to you on your book. I'm glad that we are both board certified geriatric pharmacists and getting the word out together on being MedStrong and sharing maybe it's your medications, thought processes.
Absolutely. I talk about how people, when I give talks, letting people know there are senior care pharmacists, that there is that specialty. And then to get the feedback that this message resonates, and thank you for sharing this. And you get that feedback, and we know we're on the right track, Donna, by having done these books, by getting out there and talking about this message. It's so important.
Yeah.
So
Kevin, if you don't mind if I just do a little shout out for a few things. ASCP does have a website, helpwithmymeds.org, and people can find a board certified geriatric pharmacist in their state by going on to find a senior care pharmacist. So I think that that's really important. Hedva, I want to say thank you so much for joining us for this final episode of season 2, and so excited for season 3, and I already have some amazing guests coming our way. So I'm super excited about that. I also want to say we won't be far away. We have these episodes available, right, Kevin? We have them all over the place. So definitely want to make certain that you think about the med list. And as we finished up, how important that med list is. So pay attention to the med list, have yours updated, but also listen into the med list. And I just wanted to reach out again and just say, Kevin, with your organization and company, Cedar Lake Health and Wellhood Publishing, we sponsor this podcast, and we'd love it if others want to join in sponsoring the podcast as well. So get your copies of Hedva's book. Maybe it's your medications, and my book and workbook, MedStrong. You will be well set up for taking care of the med list.
I love it. Well, on that, Hedva, thank you so much. Donna, thank you so much. Looking forward to next season and all the fun that is to come and all the things we can do together. And Hedva, we sure hope to have you back here really soon, because I'm sure you are not done yet.
I don't think I am. And if I can just mention real quickly, to access my book, it can be through Amazon, through any local bookstore. Anyone can order it. So I'm thrilled about that. But the messages are great from both of our books. I love it. Thank you guys for letting me be the end of the season. I didn't realize I'm glad I'm wrapping up the season 2 with you guys.
Well, I love it. Everybody have a wonderful night, and we'll see you next time on the Med List.